Good morning.
Good morning, Dr. Paz.
Can you see,
Yes,
you can see the conference?
yes, thank you.
Thank you. We'll just wait a moment till we get a forum. All right. All right, why don't we get moving here? Okay. This is a tracing of a Holter monitor on a patient who has hypertrophic cardiomyopathy and is 2 years following heart transplant. And this patient was having intermittent dizzy episodes. So the transplant cardiologist obtained this Holter, and this was the recording that was made. So my question to you is, what is it that we're seeing, and how would you evaluate this or think about this? So why don't we go to Dr. Bezdakova?
Good morning, Dr. Paz.
Hello.
So first thing that I'm looking at, that jumps out is that I see, looking at these rhythm strips, I see P waves without a following QRS.
Yep. Agree.
And then there's a prolonged pause between the R to R in these
So is
cycles
this
as well.
right? So that's another way of saying you're seeing some kind of heart block here, right?
Yes, yeah.
So how would you describe this heart block? We have first, I'll give you choices: first degree, third degree, second degree, and then within second you have Mobitz 1 and Mobitz 2. So what do you think we got here? Is it first degree?
Oh, sorry, I was muted.
Sure.
So I would say it's second degree heart block.
Okay, why is it
And
not first degree? Just for
so
our
yes, so looking at the interval between the P wave and the R wave, we would see prolongation
right. So
greater than 200 milliseconds, and
right.
here it does not look like
Right.
that. It
So the
looks
PR interval is normal. You mean on the conducted beats?
yes, correct.
PR interval is normal, correct? I agree with that. So then what's why is it not third degree heart block?
Then it's not third degree heart block because they're the association between the P wave and the QRS.
Yeah, there are definitely beats that are conducted, right? These appear
Mhm.
to be conducted. Here we have 3 beats in a row that are conducted. Here are 5 beats in a row that are conducted. So right, so it's not third degree. So you're right, it's second degree. So then the question is this Mobitz 1 or Mobitz 2? And let me just be clear in saying it's not really possible to tell from this tracing because we never see more than one P wave that doesn't conduct in a row on this tracing.
Mhm.
Although, maybe if we took out our calipers, we would notice a slight prolongation in this PR interval versus that one. I'm not sure. Without a His catheter in place, it would be impossible to know. But I agree, this is some form of second degree heart block. Okay, so uh, do we normally transplant hearts to recipients that have heart block in them? In other words, if Molly Marshall, let's fast forward 5 years. Molly is our third transplant cardiologist at Mount Sinai, and she's on call for transplant call, and she gets a call that there's a heart available for one of her patients, And this is the tracing from the patient who is a potential donor. Would Molly Marshall take that heart, or would she say, thank you for the opportunity, but we're going to pass?
I believe Dr. Marshall would say the latter, that she would pass.
Yes, I think that's probably right, unless, of course, the patient were gravely ill and had no other options. Right, so we wouldn't do that. So chances are that they did not transplant a heart that had heart block or of any sort in. So what do you think could be going on here? What do we worry about? I'm going to actually ask our transplant to be expert, Dr. Marshall, what she thinks about this in a patient who's had a heart transplant 2 years ago, is doing well, now is not.
So I mean, first, to your point of if it's Mobitz type 1 or Mobitz type 2, if we found that it's which it doesn't sound like it is from what you're talking about, but if it was Mobitz type 1 and the patient was like sleeping or something, that's okay.
Right. This was obtained in the middle of the day, so
Okay.
Yeah.
So then that would be concerning. In terms of what's going on, it sounds like the kid didn't have it, as far as we know, immediately post-transplant.
no, we're 2 years out, and the
Yeah.
patient's been living his best life, but now he's not. So so what do you think? What's in the differential here? Like, first of all, patient's been having intermittent near syncope. Would you send this patient home? Would you admit this patient? What would you do for this?
You said the patient's been having
He's
syncope, near
having
syncope?
intermittent near syncope episodes,
Uh-huh.
and you have this tracing.
So I wouldn't send the kid home, especially if they're symptomatic.
Okay, so now he's in the hospital, and you're getting tracings like this, maybe even see a handful where there's some longer pauses. There were, by the report of the person who told me about this case, who actually was the patient themselves, there were 7-second pauses intermittently.
Uh-huh. So very concerning. I would want to check and like do a cath and biopsy probably to make sure, especially if this is new as far as we know, to make sure it's not like a sign of rejection.
Right. So that's honestly the most important take home I want to say about this case, which is when you see a patient, Jackie Lamore laughs whenever she shows me a tracing of any heart transplant patient. The first thing I always say is he rejecting? Because rejection can absolutely mimic virtually any arrhythmia. I've seen tachyarrhythmias and usually ventricular ones and heart block from rejection. So right, so we would probably admit and do a cath in order to assess the hemodynamics and do a biopsy. So rejection, I think, would certainly be amongst the highest part of the differential diagnosis of this. But are there any other concerns that you might have aside from rejection in a heart transplant patient? What else could cause heart block in a transplant patient, do you think?
I'm not fully sure. Is it?
Well, when we do an annual evaluation,
Yeah,
what
like,
do
well,
we
because
do?
that was gonna be, yeah, that was
What do
gonna be
we
one of my
do?
questions to ask you, like, if we're looking at their coronaries, like, do patients present this way? But
Yes, yes,
okay.
they do.
Okay. I was literally gonna
Remember,
ask when we were done with the question because I was like,
yeah,
I don't know if they present like this, but okay.
no, they absolutely can. And I have taken care of more than one patient who had a heart transplant and developed coronary vasculopathy, resulting in heart block, right?
Mm-hmm.
So, which coronary supplies the AV node most of the time in human beings, the right or the left?
Believe it's the right.
Yep, about 75% of
Mm-hmm.
patients AV node is perfused from the right coronary, and so you can have coronary vasculopathy. So, as part of evaluation of somebody like this, who doesn't have an other obvious reason, I mean, there could be a million reasons people have heart block that has nothing at all to do with transplant. So you would
Mm-hmm.
look for myocarditis and check the thyroid levels, and there's all kinds of things that can cause heart block. But Assuming that none of those are the case, because most of these patients, as you know, are getting huge number of labs, that everything is being checked continuously in them. So it seems unlikely you would miss something like that. Yeah, you would want to shoot the coronaries also in a patient like this. If the coronaries were clean, probably in a case like this, we would then recommend placement of a pacemaker. Unless we thought that there was a transient reversible cause. If you had heart block, you would treat the heart block. I'm sorry, if you had rejection, I apologize. If you had rejection, you would treat the rejection. Now, if you had coronary disease, it would really depend on what the coronary disease is and whether there's any intervention recommended. But generally, the most we can do is try to stop the coronary disease from progressing. But if you already have an injury, you have the injury. You have to remember also that because the heart is denervated in a heart transplant patient, it's not uncommon that they could have ischemia and not feel any discomfort from it. So you can't necessarily take the lack of chest pain symptoms as a sign that they are not having ischemia that could be resulting in this. Now, again, this is not the worst. This strip I'm showing you is not the worst strip of all time. But again, if the patient comes in and has 7-second pauses with higher grade block, that is a concern. So the main teaching point here is when heart transplant patients come in and they are in some kind of block, or if they're having really any arrhythmia, the first thing in the differential should always be rejection. Now, it would be unusual in someone only 2 years following transplant to have coronary vasculopathy that is significant enough to cause myocardial ischemia in someone who's been taking medication properly and all. But it is still on the differential. And, certainly if someone had not had that coronary shot in the last 6 months, I'm reasonably sure that we would have recommended a full cath. This patient actually, from what I read, did have a full evaluation. I'm not sure what they found, but ultimately the patient underwent implantation of a pacemaker and did well with that, and is going to continue to be monitored. Any questions about this? Okay, let's move on to the next case. So this is a teenager who had a slow pathway modification for the treatment of AV nodal reentrant tachycardia. And this was the electrocardiogram. As you know, we not uncommonly obtain one in the recovery room prior to discharge from the recovery room, a couple hours post-ablation. So you see this, and my question to you is, any cause for concern? So why don't I ask Dr. Capon what she thinks about this? Maya, you there? I'm sorry, Ivana, you there? Can you guys hear me?
Yeah, yeah.
Sorry.
Oh,
I'm gonna
sorry.
use Christina's phone because mine's not working for some reason.
Oh, sorry.
Can you hear me now?
Would you prefer we ask somebody else, Ivana?
No, no, no.
Oh.
Can you hear me?
Yeah, we can hear you. Sure.
Oh, okay. I'm just gonna use Christina's. So looking right off the bat, it appears that we are not in sinus rhythm. This is based off rooms 1, 2, and AVF.
I'm having a little trouble hearing you, Ivana.
Wow.
Hmm.
Can you hear me?
Oh,
No. Okay.
sorry, Dr. Pence, because my headphones are plugged into me. So let me change the speaker. Okay, is that better now?
Ooh, that's very clear. Yes.
Sorry, my AirPods are in. So.
And my AirPods are misbehaving, so my apologies. Thank
Now
you
we
for-
can hear you like a radio host. So very clear.
Oh gosh, okay. So right off the bat, I have concern that we are not in sinus rhythm based off 1, 2, and AVF. I don't really see a clear P wave in 1. 2, it looks like there's a negative deflection, but it does look abnormal the way in which it kind of transitions into the QRS, and AVF similarly, and they're downright. So there's concern there. Otherwise, it appears that we are at a rate of, let's say, 80 beats per minute from a ventricular standpoint.
Mm-hmm.
Looking at our rhythm strip, it appears that every P wave is conducted, but I do have concern about this PR interval.
What is your concern about it, Dr. Capon?
It looks
You worry
narrow.
it's short, you mean?
Short. Yeah, sorry, it looks short.
Intervals are not narrow, they're short or long.
Yeah, it
So
looks
you're
like the
saying you think the PR is a little on the short side.
exactly. Yeah.
Is there pre-excitation though?
I'm trying. It doesn't necessarily look like there's pre-excitation.
I
I don't.
agree. It does not, right? We have a nice little Q wave.
Yeah,
and
but I would argue V3, like the
little
no,
bit,
actually,
but in some of
maybe
the other leads, though,
are clearly not. Yeah.
and also you'd like to imagine, though it's certainly possible, that your favorite electrophysiology team of Love and Pass would not have missed pre-excitation in someone who
Exactly.
just ablated for AVNRT.
Yeah.
But, you know, stranger things have happened, that's for sure. But that's unlikely. So I agree, we are not in sinus rhythm. We are in some kind of an ectopic atrial rhythm.
Yeah.
But since you've brought this question up, why do you think it is that I agree with you? The PR is a little on the short-ish side. It's actually probably on the lower range of normal, you know, but it is short-ish. Why do you think that is based on this P wave morphology and axis?
I think maybe perhaps where the P wave is originating from is closer to the AV node.
Right. So we're inferior. We have a negative deflection for the P wave in 2, 3, and F, right? So that means that it is coming from inferior up, meaning it's kind of coming from somewhere in the posterior region, not too far from the AV node, or certainly a lot closer to the AV node than, say, the sinus node is.
Yeah.
And so it would not be surprising that somebody who has an ectopic atrial rhythm that is arising from an area near the AV node might have a shorter PR interval than would be normally seen elsewhere. Now, interestingly, the question is this a concern that we've just done an ablation in somebody and we see this? And, for many, many years now, I have made the observation that after successful ablations, it is not uncommon in the early post-cath period to see non-sinus rhythm. I see Mahmoud is on the line. And so when I was working with Scott Seresnak, when he was a fellow and then a young attending, we would make this observation, and we always used to talk about this dream paper we were going to write on non-sinus rhythm following ablation of SVT in children, because it seemed that, like, I'm going to make a number up, but 25–30% of children are not in sinus rhythm. And it just in the first couple of hours after an ablation, they're mostly in ectopic atrial rhythm, and then it resolves. And so ultimately, the reason that we didn't write this up is because the real question is, who cares? What does it really matter if it virtually always resolves? So we didn't. Sadly, that paper remains in the dustbin of bad ideas for papers. But it's a constant. Scott and I will always bring up the non-sinus rhythm paper that we never wrote. But it is not uncommon that we see this, and it virtually always resolves. I will say, though, there was this one case I was involved in where we ablated an anteroseptal WPW patient, and after we were done, the patient was in a non-sinus ectopic atrial rhythm at about 80–85 beats per minute, what appeared to be coming from the left atrium. And interestingly, when the patient woke up from anesthesia, was extremely bothered by not being in sinus rhythm. And it was interesting because it was an anteroseptal pathway. It was a very dangerous case. We were very excited that we had successfully ablated it without causing heart block. It was a major win. And yet the patient felt terrible being in this non-sinus rhythm, and it did not resolve, unlike virtually every other case. And ultimately, we ended up having to bring that patient back a number of weeks later for ablation of ectopic atrial tachycardia arising from what was actually the left atrial appendage. And this was one of the first examples in my career where we had a patient who needed an epicardial ablation. So we actually took that patient to the cath lab. We went transseptal. We went into, it was coming from the roof of the left atrial appendage. Our signals were very early with preceding the P wave by up to 60 milliseconds. Every time we would ablate, it would go away and then it would come back. So then we, at that time, you know, you probably see that Barry and to a lesser degree, I use this catheter called a thermocool catheter, which irrigates the tip of the catheter and makes a deeper lesion. It was very hard to get a catheter like that. There was only one system in the entire New York Presbyterian at the time that had it. So I borrowed it from the adult cath lab, brought it over, burned it. It went away, and about 10 minutes into the recovery room, it came back. And so then Dr. Garan, who was then the chief of electrophysiology, took the patient to the cath lab on the adult side the next day and put about 25 minutes of irrigated lesions into the appendage. And about 18 hours later, the tachycardia came back. And then finally, at that time, epicardial ablation was very unusual and rare, and it was only being reported at the Cleveland Clinic by a fellow named Andrea Natali, who's now in Texas. And so we sent that patient to Dr. Natali, who ultimately ended up ablating it epicardially and was able to successfully ablate that EAT in that patient who had had an anteroseptal wolf. But that is the exception to prove the rule. The vast majority of patients, this just resolves within a couple of hours. So it's just an interesting observation that we see. Any questions about
So, Pass, I have a question regarding this. Let's say a scenario where you have like an EAT at a slower rate. Would that make you concerned to take him to the EP lab and do an ablation, since he doesn't seem to have a sinus node that is functioning at a faster rate, I would say? So would the fact that he has a slower rate that is ectopic make you be concerned about some sinus node dysfunction?
Yeah, well, that's a good question. In other words, does the fact that his sinus node not win against a rate of 80, is that a worrisome finding? I don't know the answer to that, Mahmoud. I mean, I think that I don't honestly, I mean, I think that probably the reason patients who have slow pathway modifications get this rhythm sometimes could be in part because we are irritating and burning in the area low in the right atrium in the posterior septal region. So it's not shocking that we may have, irritated an area of atrial myocardium and made it a little bit more excitable transiently. So I would say that in somebody like this, where we burned probably close to wherever this focus is coming from, we would make the assumption that this is just some local irritation that will resolve. The thing that's interesting about this general observation of not being in sinus following ablation of SVT is we've seen this with left-sided ablations as well, though. So it's not as simple as just that we are irritating something, but it would certainly be a minor concern that maybe the sinus node isn't working properly, but there's no real obvious reason in a person who otherwise is completely healthy and who has had multiple monitors pre-ablation with normal sinus function to have sinus node dysfunction, and certainly nothing about a slow pathway modification should in any understandable way affect sinus node function. So I would hope that that is not a sign of possible sinus node problems. Okay, let's move on to the last tracing for today. Whoops, sorry. Okay, so this was a tracing that one of my colleagues was nice enough to bring into my office and ask my opinion on this tracing. This was, I think, also a teenage girl, I believe. So why don't we ask Dr. Kailis, not Dr. Kalis, Dr. Kailis, if she could comment on what's going on here.
Great morning, Dr. Pass.
Good morning, Dr. Kailis. Finally, it only took me almost 2 full years to say your last name correctly. If not for Dr. Mukhopadhyay, we would be continuing
No
that
worries.
fine tradition of bad pronunciations.
No worries. Okay, so it looks like we do have a sinus rhythm.
Mhm.
I see P waves before every QRS. And so they're about like 3 beats into the tracing. The QRS complex looks a bit different for a few beats, in the middle and at
I
the
would
end
say
of
more
the-
than a bit different, but yes, different.
Yes, different.
Yes.
And it looks like those beats are pre-excited.
Mhm.
So I would say we have intermittent pre-excitation.
That's right. That's exactly right. This is a patient similar to our patient that we discussed last week, who has intermittent pre-excitation. And do you want to hazard a guess as to why this patient might have intermittent pre-excitation, by the way?
So
This is, you get extra credit if you can get this one right.
so I think we say that um pathways that have intermittent pre-excitation are like lower risk pathways.
Generally, that's true. We learned that according to the 2012 recommendations, if you have intermittent pre-excitation, it could, in an asymptomatic WPW patient, some would say that that is adequate rationale to do no further testing. Although, again, we discussed that there are cases where that is not true, but on average, it's probably true that they're lower risk for problems. I mean, this is, I apologize, I'm asking one of these, can you think what I'm thinking? But all I want to make, the only point I want to make is that we see that R is, it's a very, very tall R wave in V1. R is much greater than S. And if you remember back to the Aruda map that we reviewed last week, if R is greater than S in V1, in step one of the algorithm, that's very strong prediction of it being a left-sided accessory pathway. So one could argue that the reason there's intermittent pre-excitation, it could be that the pathway simply doesn't conduct at very rapid rates. But it also is possible that because the pathway is so far leftward, is so much further from the sinus node than the AV node, that maybe the reason the patient's intermittently pre-excited is because the AV node simply is physically closer and can depolarize the heart before the impulse from the sinus node even makes it to the very left lateral accessory pathway. So for me personally, when I see a person who has intermittent pre-excitation, but the pattern of pre-excitation suggests a left-sided pathway, I think those patients with intermittent pre-excitation are perhaps the ones in whom intermittent pre-excitation is the least revealing regarding risk, because the location of the pathway may be making it difficult to non-invasively tell if the reason that it's not conducting is because the AV node is sort of getting engaged much earlier. In other words, it might take only 100 milliseconds to go from the sinus node to the AV node at the crux of the heart, but it might take 250 milliseconds to go from the sinus node to a very lateral left-sided pathway. And by the time that 250 milliseconds have elapsed, the entire ventricle may already be depolarized through the AV node. So that does not mean that the pathway would not be able to conduct. It just means that the ventricle is refractory and therefore you're not seeing pre-excitation. So for me, when I see an intermittent pre-excitation pattern in someone who's asymptomatic, if it's left-sided, I am much less convinced of the low-risk connotations that 2012 recommendations would make than if it's septal. Now that's a raw pass thing. I don't know if that's actually 100% true, but if you were going to sort of take an in-between approach between never ablating people who have intermittent pre-excitation and always ablating everybody because anybody could possibly die from WPW, and there are rare cases of intermittent pre-excitation in whom the risk is not zero, I would make the argument that left-sided pathway patients probably are the ones in which this intermittent pre-excitation or loss of pre-excitation with exercise probably is the least reliable predictor of a low risk or high risk. Any questions about that one? No. Okay. Well, I think with that, we'll stop for this morning. Thanks, everybody. I hope everybody has a great day, and I'll see you at Sign Out in a little bit.
Thank you.
Take care.
Thank you, Dr. Bass.
Bye-bye.